Acromioclavicular joint reconstruction. X-ray shows a type 5 AC joint dislocation on the right. Both the AC and CC ligament torn with a displaced clavicle. A skin incision is made on top of the clavicle to the AC joint. Bleeders are ligated along the way, spreading the subcutaneous tissue, with a self-retaining retractor. The delta trapezial fascia is divided parallel to the clavicle for repair later on. The clavicle, AC joint and the proximal tip of the acromnion is then exposed. By using the arthroscope, we clean the base of the coracoid for us to pass the graft later. The scope will also help us pass through the suture to pass through the graft. With the guide of a 70-degree scope, we can appreciate the base of the coracoid. Marking of the clavicle is then done with equal length for the CC ligament tunnel. After making the tunnels at the clavicle, the graft is then passed around the coracoid. Passing of 2O ethibond at the tunnel to pass the graft with the endobutton. We also did it on the other tunnel where both grafts are passed, through these tunnels. Overreduction of the clavicle is then done by locking both endobuttons. Two sutures is then passed, medial and lateral to the acromnion, for the AC joint reconstruction. Here we can see that the graft is looped around the acromnion, for the reduction of the AC joint. We then repair both ends with an absorbable suture together. Then placing 2 Kirschner wires parallel to each other posterior to the tunnels made at the clavicle. This is to decrease the micromotion at the AC joint. Next we do delta trapezial fascia plication. Post-op X-rays showing a reduced AC and CC joint, with 2 parallel Kirschner wires and 2 endobuttons. 1 day post-op, the patient's wound is well coaptated with no bleeding.